Okay, I would like to introduce our panel discussion on addressing the gaps in serving patients with myelodysplastic syndrome. Dr. Namrata Chandok, she's a physician at the University of Miami Health System. Dr. Ashkan Emadi is a physician at the University of Maryland, and Dr. Brandon Blue is a physician at Moffit Cancer Center. Yes. Dr. Chandok, would you like to introduce yourself to our audience?
Hi, it's a pleasure to meet everyone. My name is Namrata Chandok, and I am a leukemia MDS physician at Sylvester Comprehensive Cancer Center. I thank you for this opportunity to be here, and I'm really excited to sort of join in on the discussion.
Dr. Emadi?
Good morning, everyone. Do you hear me? Yes. I'm Ashkan Emadi. I'm the professor of medicine and pharmacology here at University of Maryland Greenbaum Comprehensive Cancer Center. And my practice focuses only essentially on 5 diseases: AML, ALL, MDS, MPN, 4 actually, maybe.
And then Dr. Blue?
Right. My name is Dr. Brandon Blue. I am bringing you greetings from warm Tampa, Florida. So it's a little bit of a change for me, but I specifically focus on plasma cell dyscrasias, as well as kind of preparing patients for transplant and after transplant, as well as CAR T cell therapy, which is kind of the up and coming, as well as bispecific therapy. So some of the new cutting edge therapies, and so having a research focus on really how do we close the gaps and how do we improve diversity and access to patients with these blood disorders.
So I want to start by asking about the financial toxicity that our patients are exposed to, both pre-transplant and post-transplant. So I'm going to let each of you kind of discuss how you address that with your patients. Chandok, you can start first.
Oh, okay, sure. So the financial toxicity is immense, no matter what type of therapy we're choosing, because when you think about it, for bone marrow failure or for MDS, all of these disorders, essentially, it's not just the treatment, it's the transfusions, it's the travel, it's everything. So, as soon as they actually come to my clinic, we often try and get social work involved and try and access all the resources. And we're fortunate because more than, maybe 10, 15 years ago, there are a lot of foundation support and funds and things like that. As some of the prior speakers definitely mentioned, we have all of these newer therapies, but new therapies bring the downside of being wildly expensive. And some of them are actually going to help, hopefully, reduce the amount of transfusions, travel, all of that by switching to oral formulations, or, even if it's IV, something that can be injected at home. But realistically, it's trying to identify, what are the particular barriers for a specific patient? How can we reduce them the best, and how can we leverage all of the resources either within our cancer center or, nationally, internationally, to try and get them everything to get the best quality of life. I think that's the most general synopsis, but I'm happy to discuss more specifics after the rest of the panel.
Dr. Emadi?
I just want to share a story with you. I heard this story 2 days ago. I met a gentleman who was a CEO of a hospital somewhere in the country that they are poor. And he was in one of the regional hospitals. And then he said, the first day I started, they put 4 pages in front of me and they said that, can you increase the hourly salary of people that they clean the hospitals, janitors and whatnot, from $12.25 to $12.75. And then he told me that he said, where should I sign? So he signed that, and he said that after a few days, I was walking by, there was this young woman that, helping cleaning the. He stopped by, he said that, Dr. So-and-so, I would like to thank you so much. And she actually cried of joy. And this person that was telling me this story, he said that as this woman was asking or thanking me, I calculated in my mind that if she works 8 hours per day, 50 cents per hour essentially will translate only to $20 extra salary per week. And with tax and stuff, it's going to be essentially $17.50. And that made a huge impact in this family. There are a lot of people in this country, around this state, neighboring states, in Appalachian area, that this matters for them. And then you have a drug, as Dr. Duong presented. I just want to name luspatercept, right? The drug that does not changes the natural history of the disease. It's make you transfusion independent. Actually, when Wu was presenting, I actually looked at the price of this drug. Depends on your weight. It's $152,000 to $264,000. If you require 50 units of blood per year, each unit of blood costs, if you give this versus that, and I'm not getting into iron overload. Essentially, if you give luspatercept, it's $5,000 exchange for 1 unit of blood, it becomes $5,000. Is that what it is good? Remember, $17.50 per week changes people's life. So I can't tell you that the fact is that we do have a social worker. We find, some places to look at the finding drugs and stuff. Recently, actually, I read a book, For Money and Blood. This is the story by Nathan Wardy. This is the story of approval of ibrutinib, followed by calquence, the next one. Each of the CEO of those hospitals, after they developed these two drugs, one was pharmacyclic, the other was Acerta, after they sold it respectively to bigger company. Each of the CEOs, their wealth now is $2.1 to $2.8 billion. So we live in this country with a significant gap. And yes, they're having the great science drug is important, but we really have to think about better. And with this way, we are all, to me, the Titanic of the healthcare cost in this country is sinking, and a lot of us decorating the deck. I don't have any potential solution for that. In this country, the drug price, there's no entity to put the price on the drug, as opposed to many other, like Canada and many other even industrial country. This is sad. If you are living in Eastern Kentucky or Southwest Virginia, the nearest hospital to you, if you want to drive, it's probably going to be 3 hours. To receiving luspatercept, you probably put, with the price of gas and that amount of money, you put easily 50, 60,000 miles over a year on your car. I don't want to be doom and gloom, but we should stop a lot of things that Wu presented. They are not real science. They are associate professor makers' studies. They are not helping patients. And this is upon a lot of the pharmaceutical company and a lot of the academic people to think about this.
Dr. Blue?
It'll be hard to follow up that, but I guess I'll tell a little story myself. I think one of the things that makes cancer in general very kind of a field that made me want to pursue it was I remember when I was in training, there was a gentleman who was diagnosed with AML, and he was fortunate enough to be a franchisor of several McDonald's. And so he had quite a few children. But I remember after his diagnosis, he basically was divvying up his McDonald's franchises to his, basically saying, get the one on the north side, you get the one on the south side. And basically, each kid was basically now becoming part of the family business. That's literally same hallway right next to that patient who, again, each McDonald's is probably, bringing in probably several $1 million, was again another environmental specialist. I think, I think the word janitor, I'm not sure what the correct term is, but I want to be politically correct, but who worked at the hospital, but the hospital unfortunately contracted out the environmental services so she wasn't necessarily a hospital employee, and she also got a diagnosis of cancer. And I saw that she was struggling. Unfortunately, what happened is that due to her cancer diagnosis, she was let go from her job as the person who cleaned the floor that she was diagnosed with cancer on, because she had a cancer diagnosis, and so literally the same diagnosis for two separate, completely different people. The outlook and the treatment and things and how we treat them is supposed to be the same. like those people live in completely different worlds, and so when we talk about what do we do to kind of help bridge a gap, we first have to set aside and say, hey, we have to look at these folks as more than just a diagnosis, right? Yes, you may have MDS. Yes, you may have acute leukemia, but you were a person before that cancer diagnosis. And so we need to figure out a way to, kind of, I'm sure people have seen that old kind of cartoon where there's people who are standing behind a fence and, there's equality and where everybody kind of gets the same block, but, because of your height, you can't still really look over it. But then there's, equity where, the shorter people get a little bit of a bigger box to stand on so they can kind of look over the fence. And so I think that's really what's needed, is us to kind of look through those lenses and try to see how do we make ourselves available to the folks who kind of need it the most. And, from a practical standpoint, I don't want to take too much time, but from a practical standpoint, I think it becomes tough because as was mentioned before on the panel, transplant is very complicated, and it's not like after you do transplant, we say, all right, see you later, go back to rural Kentucky, you know what I mean? Go back to, middle of nowhere, America. No, these are very complicated things with very complicated drugs, which require complicated follow-up, especially when it comes to things such as, monitoring patients for graft versus host disease. Who's going to do that in, rural America? What does that look like? And so it becomes a challenge, right? Like if your car was already, if you're fortunate enough to have a car, if your car was already kind of getting you from point A to point B, how do you add those extra 50,000 miles that was just discussed, right? Like, how do you do that? And how do we support people from a healthcare state? This has literally nothing to do with their cancer diagnosis, but this has everything to do with how do we kind of help them as a person, And I think that we got to just be better about that. So I'll kind of be quiet there, but there's a lot to this, and this very complicated situation.
I just want to, sorry, can I jump in for a second? So, Dr. Emadi, that was very eloquent, and it was, great to sort of bring up the elephant.
I didn't practice. It just came.
Yeah. No, it was amazing, but I got depressed all of a sudden. And I think a lot of it is about recognizing that there are huge inequities in every different space for age, socioeconomic status, race, ethnicity, and then trying to create actionable changes, trying to create what we can. Of course, we need global systemic change. I don't think anyone will refute that, but I also think there are such small, like, there are particular details that we can focus in on and fix things incrementally, because I know, practically speaking, and this sounds like being pessimistic, but practically speaking, we can't fix everything, like rework the system. So we have to figure out a way to work within the system while the system changes.
You know, one thing I think is super important though, I think what we don't do probably a good enough job of is probably working together. For example, you know, I'm down in Florida.
100%.
We may have some best practices that we've noticed that have really helped, but you guys may not be doing it here in Maryland, or you guys may have had the holy grail of how to get people from inner city DC transplants. And we are struggling to try to answer that question. You know, like I feel like there are some things that we as a system, as a healthcare community can do because this is a problem everywhere. This isn't a Florida problem or a Maryland problem or even an American problem. Like, this is a problem in general, you know, but how do we put together those resources to kind of make sure that everyone is doing kind of what the best practices are, not having to recreate the wheel, not having to have a committee that has another committee and, you know, and get through some of the academic tape when it's like, hey, you know, these folks in Maryland have figured it out. This is what we need to be doing. And you know, there's different geographical issues that can, of course, become an issue, but at least we know that, hey, there's a system, you know what I mean? And how do we kind of modify that system to make it better for the patients?
Right.
So
And even
I
if you-
think, go ahead.
Oh, even if you think about, you know, someone who has what we would consider privilege, right? A white person in New York who lives like 5 minutes from a hospital. That patient, though, is 85 years old. And all of our trials are essentially done on people who are 65 years old. This was looked at 2 years ago, that we're still sort of below the mean age. We're not necessarily serving that patient best with the way we're even studying drugs right now. So I think there's like change and potential on every level, but we just have to kind of break it down into pieces and try and improve on each piece. But yeah, your points are super well taken, that we're just not doing this together. We're doing it a little bit in isolation because our system, the way our system works. And also, to be very honest, you know, everyone wants to publish their thing and they want to be, you know, first on something. So that definitely plays into it as well, to a certain degree.
So I think I have a real solution for Novartis and other people. I think the most important thing is education. You guys ought to not be selfish, all of the pharmaceutical company outside. For every dollar that you're making, you have to probably put 5 cents. I just give you 2 examples. We need to send ambassadors to the communities. We need to educate people from middle school, high school, college, graduate, postgraduate. When I had one of the hats that I wear here, I'm an associate director for clinical research. 37% of our catchment area population are African Americans. In the last 6 years, with the concerted effort of myself and some of my colleagues, we significantly educated the community that generally had a not trusting the system that well. I just presented this end of September to our internal meeting. See, we are very proud that 61% of our enrollee to our clinical trials are African American. 37% of our population are that. Why is happening? Because we are educating people. This distrust in the system is not among only ethnically and racial disparity group. There are people in this country, Appalachian. You go from Seattle, Fred Hutch, there's nothing in upper northwest of this country until you get to Mayo Clinic. The entire Idaho, Montana, North Dakota, South Dakota, there's nothing there to provide these things to the patients. You should, and those people do not trust the system. Why you need trust the system? Why you need to educate people from early on? You hook them with the science, in our case, cancer-related science, cancer research. Because when they go back to their community, they show this to the people in the community that clinical trials are a standards of care. To me, a standard of care, if you have a sore throat, a strep throat, I give you penicillin, that's a standard of care. With 8%, 10%, 18 patients that Dr. Duong showed you, these are not a standard of care. With the lousy job that we are doing, with the expensive job that we are doing, there is no other way to educate people in the country, have a pragmatic clinical trials. FDA already doing this, have changing the rules of the game. Ivosidenib approved based on 18 patients. Why? Because FDA a few years ago understand that there are this palliative endpoint. Yes, it's not curative. They put the guidelines for industry. And appropriately, some of the oral agents, that you can take, you don't have to travel. Even with a smaller number, it's palliative. But a drug like ivosidenib, one pill a day probably costs $140,000 per year, $12,000 per month. We need to do more pragmatic clinical trials. Industry must invest in the education very early on that unless there is no magic bullet, we must to educate people to understand that clinical trial, novel clinical trial, as again, Dr. Duong showed you, there are several drugs that they were great in phase 1, phase 2. When you come to the phase 3, they all fail. There is no magic bullet except for educating people and convincing people that clinical trials, good, well-designed, well-conducted study, you don't need that many of the sexy biomarkers. FDA only looking at your survival curve. You can do this in some of the rural areas in this country. Mississippi, pharmaceutical company, Novartis, whoever else, what was the other one that's supporting this? You ought to have funding in each university, in each NCI designated university to provide some funding that can grow, can be invested and bring people similar what we do here in the Schnapper with the Meyerhoff program. We must educate people early on at middle school, have a mammography. This is, we are talking about MDS. A lot of the cancer prevention can happen with education.
I'll kind of second that, but I'll kind of add one more. I'll say that education from a patient standpoint is important, but I think that what we would also benefit from is educating the healthcare system providers, because the difficult thing, especially with having blood cancers, is that you can't touch it, right? Like if you go to somebody and say, hey, I have a lump in my breast, it shouldn't be there. People are like, oh, that makes sense. I feel that. Like, duh, let's get that taken care of. Let's cut it out. Or you go and you say, hey, I have blood in my stool. They check that and say, oh my gosh, you do. Like, let's make sure we cut that out and kind of help you with that. But when it comes to blood cancers, what symptoms are you really having? Fatigue. And you say, oh, you're 80 years old, you're 70 years old. Don't worry about it. You have shortness of breath. People say, oh, well, that's normal. I thought it was due to age, there's no specific, kind of symptoms sometimes that can point to the, hey, there's a significant problem happening in this person's life. And so what that leads to is that a lot of people do go and seek medical attention, but because, the labs might be just a little bit off, they kind of get thrown around and saying, hey, this isn't a big deal. You need to go somewhere else, not here. This isn't an emergency. And so that leads to some of that distrust as well. There's some data that shows that people go see a doctor 3 to 8 times prior to them getting diagnosed with some of these blood cancers. And so imagine if you go up to the stove and you're saying, hey, I want the stove to be hot. And it's like, oh, it's cold, it's cold, it's cold. And then the one time that, you kind of need it, oh, it's hot now. It's like, Now you want me to trust it? Like it doesn't make sense. You know what I mean? And so people are like, well, where were you, 6, sometimes to 12 months prior that I've been dealing with knowing that something wasn't right. And you may have even had an MDS that has now evolved to leukemia. And now the blood counts are really off. And people are like, oh my gosh, let's kind of turn the wheels and let's start to frantically get you help, And so I do think that, patient education, I think is super important, but I think that people sometimes know when something is wrong inside their body from an intuition standpoint. But I think sometimes as a healthcare provider, system issue, again, this is not a Florida issue, this is not a Maryland issue. The system sometimes just doesn't have a good way of kind of getting people in the system who really need that kind of level of care.
I think also making sure that we're not putting our presumptions on what somebody's life is. Back to your education point, Dr. Blue, what they can tolerate, what they want. We need to make sure that they are the ones telling us. And there's a lot of data telling us that we sometimes impart our own opinion as physicians on patients. So we have to make sure we check our bias in that sense. And I think, like I said, incremental change, that's definitely something we can help with by just realizing. And I think that's where the education piece also comes into the providers. So I think that point is really well taken.
Oh, so
This
you
is
brought
the-
up, oh, sorry.
Right.
Oh, you brought up how ageism is a barrier to care, which is interesting in a disease where majority of the patients are elderly. What
Mhm.
are strategies that we can take as providers to actually incorporate these patients into our clinical trials?
So Dr. Emadi did mention one of them already, which is making sure we're doing pragmatic clinical trials.
Mhm.
So, we have barriers because we want to make sure a drug gets approved, or, we have rules and regulations that would exclude some communities more than others. So I think, I'm actually at a meeting for DEI globally. And one of the things we've talked about a lot is EGFR. And, that was designed to, from a drug perspective, you're trying to keep the patient safe, but it actually ends up excluding more older people. And then also African American patients, because the scales are created differently at this point. So we've almost built in a bias into our studies. So that's definitely something. And then actually thinking outside of the patient, when you have an elderly patient, you may actually have a caregiver involved. And caregiver lost work hours ends up being an extreme financial strain to any middle class family. You don't even have to be the, $12 an hour, $15 an hour. People are struggling. So I think some sort of measures to try and improve that as well, to make sure that people have access, is huge, and is going to be something that we need to work on, because while caregiver strain and lost work has been recognized, we haven't really done much about it. So in terms of implementable changes, I think those are the two areas that, I can give you a really open areas, but there's a lot that can go there. And of course, I'd love to hear everyone else's thoughts.
So I just want to mention my last 2 points. The first one is that when I was a fellow, there was this entity, they calling it MDS RABT, refractory anemia with excess blast and transformation. And that was when your blast was between 20 and 30%. And that went away and then AML diagnosis dropped to 20%, except for you have the core binding factor or your APL. The slides that Dr. Duong showed, I had 2 slides that essentially he covered them. This is based on the WHO and the ICC in 2022. Now, AML dropped essentially in a lot of places to 10% blast. And the line between MDS and AML could not be more blurry as it is now. And a lot of those is based on mutations. The MDS, as he showed, the MDS with SF3B1 is totally different than if you have a complex TP53 mutation, if you have RONX1 mutation. Whether you're calling it AML or MDS, it doesn't matter, as it didn't matter when I calling it MDS in terms of patient survival, MDS RAPT versus AML. So raise your hand. Who knows where Wheeling is? Okay, where is that? Where? Exactly. The price goes $5. So we had a fellow, Dr. Tina Batniger, who was in Ohio State and worked with John Bird, and she's doing a lot of essentially the same things, MDS and AML and stuff that we do. Tina is now in Wheeling, in a local hospital. I spoke with her a few days ago. She's very actually happy, but she told me something that it was very talking back to the geographical disparity, not necessarily ethnic and racial, which is also important. Tina, I guess, is a few years there. She said, I have not in the last, I've seen probably about 70, 80 AML, MDS patients in the last 3 or 4 years I'm here. I have not yet seen a good risk. I've never seen an inversion 16, 821 AML. So there's something there. And she started this project. This is happening by education in Wheeling, West Virginia, in the upper handle of the pan. Started this with her mentor, John Baird, who is now actually in Cincinnati. He's the chair of Department of Medicine in Ohio State. She started actually looking at the CHIP mutation that Dr. Duong mentioned in that area. So what is the importance of this? Another thing besides education, if you want to put in your second list for pharmaceutical company, you have to make sure that when we do the bone marrow biopsies, some of these mutations that they are now the disease defining, this not only morphology, they are covered. If the insurance are not covering, you guys must cover those things, because that will help your medicinal chemists, your people, to design drugs to attack those specific mutations, and those specific mutations may enrich in a specific racial, ethnic, geographical component. So back to I'm the director of the Translational Genomic Lab. I do this for free in the last several years. I don't get a penny because of this job. But I'm just telling you that if the diseases, if the AML is not one disease, if the MDS is not one disease, and this thing's it's not based on 20%. There was this paper, Papa Emmanuel, AML, even from 30,000 feet above, there are at least 12 different types of AML. Dr. Duong showed you based on the very low risk to high risk, MDS is not one disease. And the only way that we can understand this is finding support. Since 2010, pharmaceutical company Richmond or entity has significantly increased. Now it's your time to get it back to the community by education and helping people to understand their disease better molecularly, and help us to do better pragmatic clinical trial and deliver it to the people that they're really in need, versus age, versus geographic, versus, they are Hispanic, African American. We owe it to the people of this country. I'm not going to say one more word. I will shut up.
No, I completely agree with that. I think that whenever you have any marginalized group of people, whether that be, age, as what Sandrine was mentioning in the question, but you could kind of see similar trends among any kind of marginalized group of people to say, hey, there's a difference here. And typically that difference is not in that person's favor. But how do we make them involved in clinical trials? I think that, one of the big unfortunate issues that has happened, and this is, again, just a not institution-specific issue, is that, patients have to get to us to be enrolled in the clinical trial, and, as many patients that we see with very complex cancers at Moffit, we don't see the majority of cancer in Florida. They're done within 10, 15 minutes of that person's house. And, there's a whole referral process, and having, that person have a doctor, then that doctor send them to another doctor. And I think that if you really want to try to make an impact and try to say, that's why sometimes what happens is that we do all this wonderful science at these big places, and then they come out with what we call the real world data, and it looks completely different. You're like, whoa, we thought we were doing good. But it's because really what is representative of the people who actually make up the disease itself unfortunately, there's so many logistics and variables that were never a part of the original equation, you know? And so in order to do that, to kind of answer Sandrine's question, is that you have to make sure that we have to incentivize some kind of way for some of these local community doctors to have access to some of the clinical trials and things that we do, at these big academic institutions. And so, again, we don't need necessarily phase 1 first in human trials, but could it be, similarly to what Dr. Duong was saying, like, could they be involved in saying, all right, well, here's, standard of care, hypomethylating agent. If you put that plus venetoclax or something else in a certain population, things that are somewhat readily available and not necessarily the most, cutting edge science, but still you'd be able to include more patients and still be able to answer scientifically relevant questions. I think that would be a huge first step, because that again gets the word out and gets that education piece, because it can't just be us at the University of blank talking about clinical trials and that's the first time somebody has heard of it. But it's like, oh, my local doctor was also telling me that research was super important, or my primary told me that research is super important. So folks that are not university associated or connected still kind of having some of those same mantras, you know what I mean? And so I think that there's an old proverb that says, it takes a village, you know what I mean, to kind of make sure that things go well. And I think that the same is true when it revolves to cancer care, because again, this is a very complex process. And so it's not just going to take one entity kind of, beating the drum, and kind of, it's going to take many folks that could really make a loud sound.
I said that I'm going to be shutting up, but since he said, I'm 53 years old, I probably about 200 publications. Having a 200 one does not give me a joy anymore. Presenting in ASH is not. So I don't have any plan to retire, but what exactly he said, in the next 30 years of my life, I don't die. I actually decided about a few months ago, and I don't know the answer. For the next 25, 30 years of my life, I am going to dedicate my life to do the healthcare delivery, but not healthcare delivery to how we can deliver clinical cancer-related clinical research enterprise to the community. That's very difficult. I need help. I need some money from you. Not to my pocket, to what I have a mission. But I tell you that this is something that, I enjoy how I can deliver the same clinical trials that Wu offered to his patients. That nice gentleman that presented. To Cumberland, Maryland. To Princeton, West Virginia, which is the most south county in West Virginia near the Eastern. How I can deliver, not the first in human study, how I can deliver cancer-related clinical research enterprise without people driving 50,000 miles. I don't have the solution. I'm sure that there are smarter people than me. I'm trying to coalesce with people that there are at least, how many NCI designated cancer center we have in this country? 72. 56 of them are comprehensive. 7 of them are basic NCI designation. 9 is like a regular NCI designation. This 72 NCI designated cancer center are spread only in 36 states in the country. 14 states in this country, they don't have even NCI designated cancer center. How we can deliver, some places, even in Florida, even if you have it, you're getting a very small population. How? This is the big question. I will find some solution to that before I die. How we can, again, deliver. Education is one of them. Pragmatic clinical trial is one of them. How we can deliver the clinical research, cancer-related clinical research enterprise. That woman that $17.50 makes a huge difference in her life per week.
I think if you're
I
successful
will
at
be
that-
quiet now.
Well, no, but I think if you're successful at that, I mean, I think that's really the missing piece. You know what I mean? And I think that, you know, you say you're not the smartest person, but it doesn't take that. It takes passion. You know what I mean? And I think that a lot of times,
Try to be humble.
but no, seriously. I mean, I think that that's what it takes is that, you know, getting the, you know, conferences like this where we're able to kind of speak openly. Hopefully folks are watching at home. People have similar interests. You know, I imagine that, you know, contact informations will be shared and say, hey, you know, these are some of the things that we could do to help, you know, and really kind of make sure again, that it's you can't, again, do it alone. Right. And so you're going to need a team. And so I think that's what's going to help because that's a major change. And what'll happen, and again, hopefully this is something that you'll be successful at, but what you will notice is that whatever is able to be done locally can be scaled, right? And you say, hey, this is what worked for the Appalachian area. You know what I mean? And this is how we were able to implement these cancer-related changes. Now let's make sure that the same thing is true in the South, that the same thing is true in the West and the Northwest. And then, you know, again, it's something that just catches on like wildfires.
I want to ask one last question, and this is about our caregivers who get our patients to us. What are your strategies in supporting these very important caregivers taking care of our sick MDS patients? Oh, how do you support the caregivers who are taking care of our MDS patients?
Oh.
I'm gonna leave it open to
Doctor, I forgot your name. Doc.
Mhm.
You want to go first?
Sure.
Because I have no solution. I have no answer for that.
No, I
so-
mean, so this is why I mentioned this is our giant elephant in the room, try and fix this issue, like make it a bigger thing in our care models in general, because there is no appreciation for caregivers. There's a lot of research saying that lost work means you cannot come to your appointments, that you get substandard care. So like actually recognizing that this is an important role, I mean, yeah, in terms of practical purposes, we do FMLA paperwork, but that's not enough. So I think obviously you offer the maximum support, but I think this is a completely unsung community where we have like the worst amount of research, we have the worst amount of practical solutions, we have basically nothing. And part of it is that it ends up being the middle generation, right? The people who are taking care of their kids and then also their parents. And so attentions are divided. And in the end, you know, it's the older folks who often take the brunt of this. It's not just the MDS that you're worried about then, it's depression, it's neglect, it's all of these other things that sort of tie into their diagnosis. So we need more concrete solutions to this, but that's realistically, you know, what I have to say for right now, because I think that's an extremely underserved population. More like, you know, we often talk about trials and this and that, and then we're honing in on the patient, which is our focus as the doctors, but I think we're just not recognizing that giant problem right there.
You know, I'll just say that, and I'll speak a little bit from the African American community because that's, you know, one of the communities that I know the best. So, but I'll say that one of the big issues is that for a lot of my African American patients, they try to keep the cancer a secret. You know, I say, I'm sitting across from you, about to tell you about cancer, about treatment, about chemotherapy. Why are you by yourself? You know, oh, well, my family doesn't need to know that. I don't want to be a burden, right? And they don't have a caregiver at all, right? And so I say, that's not gonna fly. You know what I mean? And I almost have to force them sometimes to say, all right, well, they can't come. Let's call them. You know, let's do Zoom. Let's do, you know, let's figure out some kind of way to get somebody else involved in your care, you know, because I think, you know, a lot of it, people, again, first of all, having cancer itself from a cultural standpoint, especially in the African American community, a lot of Black folks don't even like saying the word. You know, I have, you know, they come up with creative things. You know what I mean? I got low blood. I'm like, nah, you got MDS. You know what I mean? Like, you know, but people, you know, and so it becomes an issue of, you know, my grandfather died, and I don't really know why, because they never told us, right? And so we talk about trying to figure out mutational changes, mutational analysis, familial patterns, and we don't even have people within the same household who's sharing their diagnosis with somebody who they see every day. And so I think that it becomes really a big issue, because to make the caregiver involved, we got to understand some of those cultural norms, you know what I mean? To say, hey, and again, I kind of keep it very honest with my patients. I say, no, I understand where you're coming from, but we're going to try to change that. You know what I mean? And this is why this is important. And so, unfortunately, there's certain groups of people, again, from a cultural standpoint, that have a tendency to be the either matriarch or patriarch of their family structure, right? And so, unfortunately, them being diagnosed with cancer, it's somewhat considered to be a weakness, right? To say, hey, I'm used to going to grandma's house for Thanksgiving and Christmas and, all the fun stuff, not taking her to chemo, you know what I mean? And so I think just having some of those perceptions be a realistic thing that happens really all the time. I think that unfortunately we have to kind of figure out a way to just kind of because again, most people have at least somebody involved, but again, it's the education and sharing with that person. No, this is exactly what your loved one has been going through. The times that they say they just going to the doctor, going to the visit, they were actually in the chair getting transfusions. They were actually, getting some very complicated things happening, not just going to the doctor. You know what I mean? And so I think that people sometimes keep it vague on purpose, but trying to make it be purposeful to kind of let them know, say, no, they're going to need your help, because we're thinking about doing this very complex treatment that there are going to be days when they don't feel well, and they need to have somebody who understands who to call, who, us as the doctor say, oh yeah, I know your daughter, I know your grandchildren, I know, some familiarity of who is involved in your loved one's care. And I don't think we do a good enough job of that. But I will say that we have to make sure that, we understand culture, because culture is super important.
So I think that we are at the end. For a pharma company, I gave you two tasks. One, invest in education. Number two, invest in diagnostic, the molecular diagnostic. Number three, answering this incremental question, you must invest in any cancer center, regional, comprehensive or not. There should be, depends on their analytic cases per year, there should be hope lodges, hotels, that they are near that place. That will eliminate the transportation issue, even in some of the rural area. You must put money. If you want patients, pragmatic clinical trial to be enrolled in your next forefront of science, that woman that I told you, the $17.50, if she leaves the work to her husband has a lung cancer, MDS, she's not going to get paid. But if you have a hope lodge, a hotel nearby any regional cancer center, people can stay there. The loved one, the caregiver, they are not worried about them. They can easily, with the local transportation, if it's near the hospital, can come get their regular chemo, regular care, and then stay there. That's a very incremental. The easiest issue, it's not going to solve the whole caregiver problem, but one thing, the third thing that you must invest near any cancer center in this beautiful country, you must invest in Hope Lodge Hotel. Team up with the head of the hospital, CEOs. That helps a lot of caregiver issues.